Good afternoon. I want to start by thanking both SAGEs and the moderators for the opportunity to present. My name is Laurynn Garcia. I'm a third-year medical student at Baylor College of Medicine, and I'll be presenting our work entitled Comparing Utilization Rates and Perioperative Outcomes of Intraoperative Cholangiography and cholecystectomy. I have no disclosures. So we're all familiar with the cholecystectomy and know that the laparoscopic approach is considered gold standard in comparison to open approaches, with also increasing utilization of robotic approaches as well. However, these procedures are not without complications, one of the most feared being the bile duct injury, with literature suggesting that this complication may be more common in these minimally invasive approaches over open approaches. So SAGES has promoted the Safe Cholecystectomy program, and I want to highlight number 3, which includes use of cholangiography or other methods to image the biliary tree intraoperatively and enhance the critical view of safety. And some of these methods that we've employed have been the cholangiography under fluoroscopy and the ICG cholangiogram, as well as ultrasound. Of note, the ICG cholangiogram has been easier to employ and also more time efficient, so that has become more popular in our institution. So our objective with this project was to examine the utilization rate of intraoperative cholangiography during these minimally invasive approaches, and also look at the clinical outcomes among patients who had these done versus those who did not. So we did chart reviews on patients who underwent either laparoscopic or robotic cholecystectomies during August 2020 to July 2022 at our institution. And we analyzed both the rates of cholangiography by surgical approaches as well as perioperative outcomes. And so overall, we had 192 patients who underwent these minimally invasive approaches, with 131 or 68% of them that received some form of cholangiogram. So this graph is demonstrating cholangiography use stratified by surgical approach. I'd like to note that with robotic, there was a higher use of the ICG cholangiogram in comparison to the laparoscopic approach, and also that for 6 conversions from to open from laparoscopic, majority of those patients did not receive any form of cholangiography. Looking at complications, we had 27 patients noted to have any complications, no including bile duct injury and 1 death. And when we looked at these rates of complications for patients who received a cholangiography versus those who didn't, we actually found higher rates of complications in those who had received a cholangiography. We also looked at our total 30-day readmission rates, and for patients who received cholangiography also had a higher rate of 30-day readmissions versus our patients who did not have any cholangiography done. Looking at same-day discharge rate, so there was a lower same-day discharge rate for patients who received cholangiography. However, if patients were admitted, those who received cholangiography had a lower length of stay at 3.5 days compared to 4.9. And so what we can conclude from these findings is that majority of our patients are undergoing intraoperative cholangiography under a minimally invasive approach, and we're predicting and hoping that this will increase as we develop new technologies and as patients or our surgeons become more familiar with these technologies as well. We also found a higher rate of the ICG cholangiography in the robotic cases versus the laparoscopic, likely due to our surgeons' preference and familiarity with our technology. Overall, we also noticed a higher trend for complications, 30-day readmission rate, and a decreased same-day discharge rate among patients who had a cholangiography. This is possibly due to selection bias, as surgeons are more likely to employ cholangiography for more difficult, more complicated gallbladder removals, as well as challenging and complex patient clinical history. So in the future, we plan to investigate the efficacy of cholangiography by analyzing preoperative factors such as imaging findings on CT, labs, BMI, patient comorbidities, and disease severity, and correlate them with our intraoperative findings as well. That concludes my presentation. Thank you.